And good evening, everybody, and welcome to this latest in the series of SAMinars. This is the third one of our second series, the 8th overall. And please say we've had over 400 people register for this from 10 countries. So welcome to everybody. Slightly different format tonight. We've got 3 plenary sessions and 3 abstracts. We'll be starting off with a plenary session around ambulatory care and consultants working from home. Then we'll have a short 5-minute question and answer session, followed by a talk from Lizzie at the Royal Brompton about dysfunctional breathing and COVID. Then we'll have a quick 5-minute break, followed by the 3 abstracts from around the country. And we'll wrap up with our last speaker, Paul Sullivan, talking about quality improvement in acute medicine. Before we go on, we have a quick advert. We are planning on running a conference this November. The minimum we'll deliver will be 2 days of online education and webinars. And we'll be really glad to see you logged in and registered for that as soon as possible. We've got loads of high quality abstracts and a really good program. It's all on the website if you need it. Here's tonight's talks again. For those of you who've been here before, you know how to ask a question. For those of you who are new to us, there's a Q&A function at the bottom of Zoom. Please use that for asking any questions of our talkers. If there's anything you want to comment on that's not a question, please put it in the chat. But please put your questions in the Q&A where we'll get to them. If they're not answered live as we're talking, there's every chance you'll be able to get them answered by the talkers later, who should type in some answers. We do have a few questions. We've got a poll to ask you before we kick off. So the first question is, what's your current role? I'll give you about 5 seconds to vote. Okay. So we've got a large proportion of consultants getting their CPD in. We've got some trainees, registrars, nice to see some nurses, PAs, pharmacists, and a few others. So move on to your second question. What is your speciality? And 88% of us are acute medics, with a few others. We've got 1 emergency physician and someone from primary care as well. Welcome to you all. Now moving on to the 3 main topics today. So, what is your current understanding of the off-site consultant working in ambulatory care? Okay, hope we'll improve on that. Next one, your current understanding of dysfunctional breathing, the complexities of COVID-19 recovery. And moving on to our third question on the talks. What's your current understanding of quality improvement in acute medicine? A little bit more awareness in that subject. So, without further ado, I'll welcome our first speaker, who's going to be talking about off-site consultant work in ambulatory care, the COVID-19 response and developments for the future. And it's going to be presented by Anne from the University College of London NHS Hospitals Trust. Thank you, Anne.
Thank you. Can you hear me?
Yes.
Yeah, I've unmuted. Lovely. Hi, my name's Anne. I'm a consultant nurse in ambulatory care or in acute medicine. Looks like I've got control of the screen. Okay, and basically this is off-site working in response to COVID-19 and what we can take forward from what we've learned during the COVID pandemic. Oh, hang on, I've gone forward to it. So, gone too many things. So pre-COVID, so in March time, we have an ambulatory care which has 6 clinic rooms. We have 1 acute medical consultant working Monday to Friday between 9 and 6. And then the rest of the staffing is a combination of junior medical staffing and ACPs, for which we've got 5 trainees and 1 qualified. And prior to COVID, we were seeing 40 to 50 patients. We were process driven, so we would take anything that we felt that we might be able to turn around and get home in the day. And then we also had a telephone clinic, which we've been running for quite some time, where we were phoning between 5 and 10 patients a day. And then obviously COVID came along. And the first thing was that 2 of the staff, 2 of our medical consultants were pregnant. And we were told based on government trust advice, they shouldn't be on site. And they went home, both very early stages of pregnancy. At least one of them had not even told the remainder of their family that they were pregnant yet. Our junior doctors were pulled from the clinic to man the COVID inpatient area, so there's reallocation of medical staffing. And the ambulatory care was in a designated clean area. So that left us with consultant gaps. And it was felt that the main thing that we should try and do is see if we can have the consultants who are pregnant to trial remote working to cover the clinic. And then that meant that our other consultants were free to focus on the inpatient working. We wanted to keep ambulatory care running because we felt that there was a need to still see some patients who could be seen in a dischargeable area. We wanted to keep it a clean environment so that people felt more safe coming into that environment. And we deliberately saw no COVID presentations. So basically the service became run by myself as the consultant nurse and the ACPs who were actually on site. So our numbers fell initially between 8 and 15 a day, but our telephone clinic increased exponentially. So the consultants who were working became responsible for the telephone clinic, which previously had been something I predominantly did. And they did the phone calls, and at one point they were phoning 20 to 25 patients on a daily basis to have contact with them. We were able to forward the referral phone number for the GPs to the consultant, which meant that they had lots of conversations with the GPs, particularly in the early stage when GPs weren't seeing patients themselves. There was a lot of advice giving. I went full time into the clinical area. Normally I'm only 50% in the clinical area, and for probably 3+ months, I worked full time in the clinical area. I accepted ED referrals rather than having to phone the consultant, and generally manage the flow of the clinic, which usually is something that the consultants oversee, who's seeing what patients, where they're going, what's happening with them. And the consultant took referrals from the GP and gave advice, and they did the telephone clinic, which I think that prior to that, they didn't realise how time consuming the telephone clinic would be. So what happened on the daily basis? Our ACPs saw the patients. The senior review was either by myself or remotely from the medical consultant. I think a lot of this was very possible because we introduced an electronic health record. So we had Epic. We had it for just over a year when COVID hit. And I think because of that, the remote working consultant was able to see all the clinical records and imaging. So they could actually see everything that the ACPs were writing. They could see all the imaging that had been requested. They could see all the blood results. They could look at everything that was being done remotely. We became very adept at uploading pictures of legs to look at, of rashes, so that they could see all these in a real-time basis. ECGs were uploaded. Everything was available for them to see that they would have had normally in front of them. However, what we did think is, where are our usual referrals? What's happened to our DVTs and our PEs and our CAPs that normally come through? And we didn't see a lot of them. What we did realise a couple of weeks later is we were starting to see them, but very late. So we were seeing people where their illness was much further advanced. So for example, we saw people with DVTs where their whole leg was so grossly swollen that it couldn't be in anything else, but they had delayed coming in because of COVID and not being able to see their GP. So feedback from the floor from my ACPs, they felt there was a real consistency of the accepted case mix from the referrers. So they tended to get what they felt was very similar presentations. So we didn't have these, we didn't have random people booked in, which we sometimes get. They felt the practice was safe. There was always seniors around. We still had a tape consultant. There was still registrars around doing the tape team. So there was always somebody we could always ask if we couldn't get through to the consultants. There were the same consultants for 6 months that gave us continuity, especially with follow-up. So quite often both consultants would say, book them in to come back in 2 or 3 days, particularly if they were complex, because they knew the case and they knew that they would be the consultant on call for that day. So they would have this conversation with them. The ACPs grew in confidence. Prior to this, they rarely worked on their own, and they really grew in their confidence about their clinical skills and seeing people. A side effect was nothing really to do with ambulatory care, but this was the most time that the ACPs have ever spent with each other. So they effectively built some teamwork for themselves, and they're very much more engaged as a team. And that's really just because of the rotas, and because they were on lots of study leave, they were intermittently saw each other. But this, because they were all had no study leave, they were all there a lot more. And the consultants were so engaged with us. They were really negated their absence. They were very concerned. They didn't think that people were getting seen. They would often call and say, what's happening, there? Are we struggling? Do they need to, do they need to cut down on the referrals? Do they need to ask people to come in a bit later? Shop floor, the main thing they missed was the face-to-face contact. They actually liked being able to see the consultants. They liked being able to discuss some of the complexity. And they felt the time was limited due to calling the consultants on the phone. One of my ACPs said that actually the consultants became her favourite phone number that she was calling above her mother. Teaching opportunities they potentially felt were missed. They didn't feel that they could spend the time asking the same level of questions that perhaps they could, though the consultants' time was no different when they're on the shop floor because they're taking the referrals, they were seeing patients. I think they felt they couldn't ask quite the same questions. Sometimes the consultants were too engaged. There is on our electronic system, there is a messaging service, and sometimes the plans were being offered before the patient was being seen. So they sometimes felt that that was just a little bit jumping the gun. And maybe there was more patients admitted. I can't say that's definite, but we know of probably several patients who were admitted that then went home when they were actually reviewed on the post-take ward round. And we think that was more that it's actually quite hard to gauge how well somebody may look or get a feeling for a patient when you're actually standing in front of them versus what you can see in numbers and what somebody's telling you over the phone. And I think that definitely some of the patients were less sick than perhaps their numbers look like. And then, so this is before Tam went on maternity leave. She gave me some of her feedback from having worked at the other side of it. And she was originally supposed to do the presentation, but is now currently on maternity leave. So from her point of view, the first thing was it was really nice not to have to commute while pregnant. And having access to the IT systems at home made this so much easier for her. She loved the live chat function to communicate regularly with the team rather than waiting for phone calls. I think she felt that sometimes that she could actually get that feeling of making people sort of do various tests in advance and then waiting to have everything all together rather than ending up having a phone call where she says, well, I think you need to do this, and then call me back when you've got the results of that. There was more, she felt more focus on the management and the efficiency running of the unit. It definitely filled up clinic space and computer space for others to use. I mean, it's an ongoing issue that the consultant who takes referrals, even now, rarely has their own space. And what happens quite often is that they sit down at one computer and they're there for literally, if they get up for 5 minutes, when they come back, that computer is no longer available for them to use. So I think with the phone clinics, we also didn't always forward the phone referral to them until they'd finished doing the phone clinics, which meant that they felt free to actually speak to patients. So there was some privacy. They recognised it was a steep learning curve for the ACPs and that they started to work more independently as well. I think there were certain things that they recognised, and maybe it's because the continuity with the ACPs that they recognise certain questions they got from all of them. So sometimes they would be sending through teaching packages on how to manage hypernatremia, for example, because it was something they got from all of them about what do I do with this patient. The ACPs are much more confident in coordinating the clinic, and they felt that this was the continuity with the ACPs was better than with the trainees who rotate, because the ACPs know how a lot of the systems in the hospital work. They knew how to get scans, they knew who to talk to, that maybe bypass some of the sort of bureaucracy of getting some tests done. Downsides from their point. We were one of the very few outpatient clinics running in the hospital, meaning we came everything to everyone. And that meant that we got quite a few what we would call non-emergency requests, where people just didn't know where to go to get a patient seen. There were more GP phone calls, particularly when patients were being seen less face-to-face. And I think that also caused with the GPs quite an increased anxiety due to the new ways of working. I mean, I think that reflected as well that sometimes we would see patients having accepted the referral from the GP, when you actually talk to the patients and you saw them actually bared little resemblance to their actual referral reason. There were more calls from other hospital specialities wanted to use our clinic space as hot clinic area, and which has meant longer term we have some problems with social distancing in our waiting room, which continues. We went from a waiting room that could easily accommodate 20 to 25 to a waiting room where we're basically saying only 5 patients should be in at a time. There were more calls from GP for diagnostics, which were cancelled due to a pandemic. An example of that would be we had one GP who continually asked us to do ECGs on patients because they needed to start medication recommended by neurology, and they had no way of getting just a routine ECG done to measure QT time. Anecdotally, they also felt we had a higher investigation rate for patients due to a less senior review on the shop floor. So I think that probably reflects that the decision making that you can make remotely versus when you actually see a patient. This was something Tam said, junior doctors not following up on their own results for patients they see, and hence there was more burden on the consultants to do so. I think they reviewed a lot more results and ended up with more people in the phone clinic based on the results that they were following up. And they had some more non-medical emergency presentations because patients wouldn't go to ED, or more referrals from them. And we didn't actually see those because they felt that ED was the most appropriate place for these people to go. An example of that would be people with a fall and a head injury, which we wouldn't usually see in ambulatory. And then lastly, I think from Tam's point of view, it could be lonely. Because she was on her own for sort of 6 months. She was only coming out for maternity appointments for the first 4 months. So actually having the access to MS Teams and colleagues was good, but also to make sure that you had non-related calls, because otherwise it's quite a lonely existence when you're on your own in a house and running a clinic for 10 hours, and all you get is work-related phone calls. So in mid-April, our referrals went up into the 20s. Lots and lots for us of post-COVID illness, and with a steep learning curve for the team, and perhaps more investigations than normal. But I think some of that was being guided because we didn't quite know what we should be doing. And since then, more pathways have developed. The area remained a clean area, and we started pulling back some of the junior doctors who were maybe not seeing as many patients as people originally thought, or things had settled down in ED. So they started coming back as it got busier in the clinic. And but we made the decision to keep remote working for the consultants because it seemed to be a system that was working well for us. So where do we go from now? So we increased use of telephone clinic, and I think it's something that we've learned that we need to really think about. Should this patient actually be coming back into hospital just for results? We could, or pending things, or simply a symptom review. And I'd like to look at more virtual video clinics, but we don't currently have the software and hardware available in the clinic rooms. It's on order, but it hasn't arrived. It was been on order for since the second week of COVID, so I'm not overly optimistic at how quickly it's going to arrive. But that, I think, would be one way of reducing the number of people who actually need to come in. I think it should be considered as a way for us of working to allow people who are working from home, even if they're not shielding, as a way to reduce the number of people having to travel into the trust. Also for people who perhaps have to shield or having to self-isolate, to ensure that people can continue to work even if they've had to self-isolate and aren't unwell. However, it has been nice to have the consultants back here in person. I can feel it's not that it wasn't good and having it on, occasionally, but I think there is something around having the consultant there, that how they're reviewing patients makes a difference. The teaching is definitely different. People feel more able to feel like they can spend more time asking the questions that they want to ask. I'm not sure how replicable it would be without access to our clinical system or something similar, because I'm not sure how you would manage a system if you're relying on a consultant reviewing a chest x-ray or an ECG, how they're going to be able to see all the results if you don't have that sort of electronic system available to somebody. That definitely was key to being able to do it. And social distancing is reducing the number seen, so it is feasible for us to continue to do it with somebody working from home, because you're not talking about vast numbers. And then really that's all I had to say about them. Questions? I probably finished a little early, which originally Tam was going to co-present with me, but as I say, she's on maternity leave.
I hope she's well. But
Yes.
as you finished, I say we've got lots of questions. Thanks to everybody who's been sending them in already. Trying to break them down they sort of fall into two categories. The first category is around how did you keep your clean area clean, given that you were taking pneumonias and query PEs, and how did you make certain they weren't?
Okay. So I think that one of the first things we actually did, we normally would stream CAP and query PEs, and they were the two things that we stopped streaming from the A&E front door. So previously they would be so we were very strict. So our consultants was any hint of COVID, they went to A&E into the medical take, and we stopped the two highest risk groups coming through our navigation system from ED. So we basically didn't see them. And if they were had COVID, we would take them 14 days after COVID if a GP referred. So that's how we kept it clean from those. With the long-term plans, we're currently looking at an SDEC service that is going to be 36 spaces to see people, and 4 of those are going to be designated as SDEC COVID, where they're isolated behind dials. So we have learned from that we need to be able to see some of the COVID patients, because we ended up giving people enoxaparin and low molecular weight heparin for quite often 2 weeks, because we thought they had a DVT, but they weren't unwell enough to come into hospital, so that prior to scans and things. Some of that was patient choice as well.
Okay. Question from Dr. Crossland. How did the remaining consultants sort of on the shop floor deal with their colleague remoting in and doing the work?
They all seemed happy, but I guess that is actually a question I forgot to ask them. Nobody said anything. I think they felt it was a good use of time, because I think the concern was that how the work was divided up during COVID meant that it would have been a push for them to have been able to cover ambulatory care. So this gave them a dedicated somebody who was actually covering that without them having to worry about it.
Was there ever an occasion where one of them had to come round because of something happening, the remote consultant?
Yeah, so our take consultant was always available to see patients that we were very worried about. And if the default, that's probably if we had somebody who was very sick that we felt that we needed to admit, or that they are more unwell, we had our emergency assessment unit. We're co-located with that, so we would put somebody in a bed and we would ask the take consultant to come and see them, and they were all within the same physical location.
Okay. Question that's coming on the chat I've just seen. Were there any medical legal things you had to jump through before you could do this regarding remote working and
No,
consultants?
the trust set that up. So they arranged for vast numbers of the trust can do remote working. So they set up a Google Authenticator and various systems so that people could access it, basically with doing a VPN type environment, so that they were accessing it. Nothing on Epic, the system we use. It's you launch into the platform, but nothing is downloadable onto your PC.
Okay. And probably a very frequent thing that a lot of us could be asking, what were the IT issues? Because most of us have systems that we can log in to work on, but they are frustratingly slow.
No, I mean, neither Tam nor Sheena mentioned that they had any problems getting into Epic. I've used Epic remotely myself, and we've had no problems. You can download an app for it. So I've got the app on both my iPad, I've got it on my iPhone. You can download it onto your PC. And if your Wi-Fi is good, then you don't really have a problem getting into it. I think initially they might have had one or two problems getting into the imaging, which loads on a PACS theme. But again, that's something that IT here had worked out. Vast numbers of our radiologists were reporting remotely throughout COVID.
And was there some sort of live chat through Epic so you could talk to each other through it, or?
Yes, yeah. So it's like it was like Messenger, but it's completely secure within the Epic system. And you can use it for multifunctions. You can do it just to chat to a member of staff about something, or you can attach patient details to it and say, can we talk about this patient? I mean, I've used it before to say, is there any chance we can get an earlier echo to the echo text? Or Tam would have been at times, because she particularly liked it, she would have been saying, I've noticed the sit to stand is this, can you check their TFTs please before you call me? That type of stuff would be going through that.
And I think the final question moving forward is, would, would you ever consider building on this to use video consultation with patients, perhaps in their own home, or wheeling it
Yes.
around the AMU, or?
Yeah, so there is a video consultation option within the Epic fields, and we have looked at that. The only thing that's slightly against us doing it on ambulatory care is that you need to send out the patients a secure link for them to be able to log in. And that may not work quite so well in ambulatory care, because generating that link normally is sent out in a letter or an email. So we would have to look at how we could do that for people who are being referred in for the same day. So I definitely want to look at that, which is why I've asked for video abilities to be installed in 3 of the clinic rooms, so that we can use that as an alternative. And that might be something we want to do with our telephone follow-ups, make them video follow-ups. So particularly if we want to do like review somebody's leg, if you're treating them with antibiotics or something, to see whether things are improving, because of the fact that we can take photos, we can actually then give a comparison even if we've not actually met the patient.
I suppose my last question that I'll take is, going forward, is this going to be the new normal for the way you're going to work ambulatory, even when Tam's back from maternity leave?
No, I don't think we'll go wholly remote. But one of the consultants who is due to do ambulatory care tomorrow, she is currently isolating and she is working remotely. So I think it's an option that we should explore. And I don't think we should say we shouldn't ever do it again, because I actually think there were some benefits. It does promote some independence in some of the practitioners and makes them really think about I think the other thing is it makes them really think about how they're presenting the patient, because they felt they had I don't know why they actually felt they had limited time, because they were quite happy to talk in the same way they would normally, but it actually made them really collect their thoughts before and they came up. It made them, for the ACPs, it made them actually start coming up with a plan rather than just, oh, here's this patient, what do you think I should do with them? They actually came up with more plans. So that's what promoting the independence and autonomy has done for them.
Great. Well, that was fascinating, and a lesson to us all of what we might need to be doing over the next few weeks and
Yeah,
months.
yeah, I know. We may all be back, to where we were before. Yeah.
Thanks. Cheerful note. Thanks a lot for that. That was great.
Thank you.
So moving on, our second plenary talk tonight is from Lizzie Grillo, who works at the Royal Brompton Hospital. And it's a talk that I suspect not many of us have thought about before. This is entitled Dysfunctional Breathing, Complexities of COVID-19 Recovery. Thanks, Lizzie.
Hi, I hope everyone can hear me. So that's it. Right, thank you. So thank you to the organisers for inviting me today and to share a platform with these really interesting speakers and talks. I'm a physio who works at the Royal Brompton, and today I'm going to try and explain a little bit about dysfunctional breathing and how it may impact in COVID-19 recovery. So the aim of the talk is to really give an overview. There's a huge amount of content I could cover, but I am going to try to talk about what it is, how we might assess it, including some extra layers that you might want to consider. And additionally, I'm going to try and share some early information about what we understand of its potential impact in COVID. So dysfunctional breathing describes a group of breathing disorders where patients describe changes to their breathing that results in dyspnea and often quite a lot of non-respiratory symptoms. But often these symptoms of breathlessness particularly are unexplained by any physiology. And there are a number of different terms that are used, which makes the nomenclature around this condition quite confusing, both clinically and in a research world. But if we can recognise this condition, we can refer it on, and in the right hands, it is a condition that is very treatable. So it's important as well. It's a condition that is quite common, especially if you're female and especially if you have coexisting asthma. It can be present with pathology as well, so it could amplify your symptoms of disease, but it also may commonly present with no pathology at all. And there's a significant impact on the patient because misdiagnosis can be distressing. And I think even more importantly, some patients can be waiting up to 7 years before a diagnosis is being made, which can be really frustrating for the patient. And I think as well, there's health economics to consider, where quite often patients where symptoms are amplified, either in primary or secondary dysfunctional breathing, they could be on medications that they don't need, which obviously has significant cost implications and quite often side effects from medications that are also unwanted. So I suppose to remember what, or rather to understand what dysfunctional breathing is, we need to understand what kind of normal breathing or functional breathing should be. And functional breathing is something that's adaptive, it's appropriate, and it's responsive to what we're doing. So for example, if we exercise, our breathing will be efficient for what we need to do, and we'll also return to normal once we're recovering. But when it's dysfunctional, it becomes non-adaptive, not appropriate, and not responsive. And that disturbance or inefficiency with the control of breathing is where some of these symptoms arise. So there's many ways that we can start to find a pattern of this discordance. And this slide aims to sort of pull together some of the thoughts where dysfunctional breathing as an overarching term may have 2 or more impacts to it. The biomechanical impacts, where your breathing pattern is adapted in how you're breathing, but also perhaps hyperventilation episodes where your biochemical aspects are disturbed and the patients are actually either acutely or chronically breathing in excess of their metabolic requirements. And it's important to emphasize again that this can happen in the place of disease, but also in the absence of disease. Additionally, patients can experience these symptoms acutely and chronically as well. So the literature has begun to describe different types or different phenotypes perhaps of this condition, which we've already discussed. Hyperventilation is our most common one, but it's not complete to just be thinking about this. There are many other aspects that we need to consider as well. So one of the analogies that I tend to use to describe the problems to a patient is a volume analogy. So I'm going to try it with you now. So if you think of your breathing as a scale with a volume switch, that volume switch turns up and down depending on what your breathing needs to do. So at the bottom of the page, at the bottom of the arrow is our normal breathing in inverted commas, where our flow, our frequency and our tidal volume is comfortable and appropriate. Different things might increase, might turn our volume up. That might be exercise, physical activity, talking, coughing, laughing, all those other things where our breathing is impacted on. And what can happen in breathing pattern problems or dysfunctional breathing is there an increasing maladaptation to that breathing pattern where your baseline is starting to move up and down that arrow. I don't know if you can see my cursor, but it may be that your baseline sits in the middle, meaning that you're nearer to this point at the top where you're going to get uncomfortable symptoms. sorry, just one back. And it's important to recognise at this point at the top, it could be that there's physiological symptoms like hypoxia or the impact of COVID-19 in an acute state, pushing your volume right up. But additionally, when maladaptation to breathing pattern happens, this could also be where we need to start treating the patient to recognise when they turn their volume down. But there's so many potential sleep symptoms with dysfunctional breathing, and people don't often perhaps reflect on this enough. Respiratory, cardiac, neurological, palpitations, chest pain, dizziness, paresthesia. Respiratory symptoms are paramount. They're often the one that drives the patient to our door, and often the patient will arrive with these complicated symptoms. And they may also experience other symptoms that contribute to well. And therefore, they present often in quite a chaotic way. So to think about you guys that work in acute medicine, let's just think briefly about a patient now. They might arrive at the door breathless, unable to take a deep breath, have a tight chest, air hunger where they're sighing or yawning a lot. Because of flow and breathing a lot through their mouth, they may have a lot of laryngeal irritation. Now, it goes without saying that you're going to be doing multiple tests and investigations to confirm or unconfirm diagnosis in physiology. But obviously, these patients are often time consuming, conflicting. They may have had frequent hospital admissions, and the psychological impact on the patient can be quite profound. And as a clinician, that can be quite frustrating. So how do we assess it? How do we pull this apart? Well, obviously, the referral to us is the most important. And there's many different aspects that we look at, of which I'm not going to go all into now, where we take a comprehensive subjective history, objective history, which I'm going to come back to with one of the schools that we do. We quite often use different objective measures and patient questionnaires to start to characterize someone's breathing objectively and subjectively. But I think what's really important is you've got to assess the patient with empathy and take on board the patient's insight, because of the fact that you need to understand if they're going to engage with you on a course of treatment. And quite often I say to people that the assessment's the most important one, because if that goes badly, if the patient is thought to be called, oh, it's all in your head, just breathe properly, that can be really unhelpful. So there needs to be a really empathetic approach here. And I'll come back to this with regards to COVID. I mentioned that I talked to you a little bit about how you assess breathing objectively, and this may be something that some of you might want to use in a practical sense. So this is a clinical assessment tool that we designed at the Brompton to evaluate breathing pattern by taking some of the key aspects of assessment and putting them into a scoring system. The scores range from 0 to 14, with a higher score indicating an increased change from normal. And some of early evidence that we've done in it shows that there's significant difference in this compared with asthma. So BPD groups either with or without asthma show higher scores than asthma alone. Just thinking also about another questionnaire that you may have heard of. This questionnaire is called the Nijmegen questionnaire, developed by a group in the Netherlands, and it comprises 16 questions around respiratory symptoms, 7 specifically to respiratory symptoms, 4 more about the kind of physical ventilation, and 5 concerning central nervous systems that are often linked to hypocapnia. Originally, this was to do with assessing hyperventilation, but the authors more recently have said that it's a good assessment of functional respiratory complaints. So it's a good questionnaire, but it's important that it's not a catch-all, because some patients with dysfunctional breathing without significant impacts of anxiety and hypoventilation may score quite low on this measurement. And in terms of treatment, there's many facets, but it centers around education, because education around normal breathing and self-awareness and understanding is paramount. In addition, it's that extension of the validation of the condition itself, even though there may be a removal of other diagnoses, which can be uncomfortable for patients. It's a problem in itself that needs focus. And obviously fundamental to the treatment is breathing retraining, which essentially is anything that helps us to reduce the minute volume and normalize breathing pattern, of which there's many different ways that we can approach that. Additionally, there's many other factors that are also important that we don't have time to talk about in detail now, but there are other aspects that we need to cover within that physio treatment. And physio treatment can cover over sort of 2 to 4 sessions. But I suppose some take-home points for you guys at home. Just checking. Move on the slide, please. Great, are these two. And again, I know the slide is busy, but just to take home, nose breathing is paramount. The way that it helps us to control our breathing, filter the air, add resistance and reduced flow, and also teaching a patient comprehensively how to perform breathing control. Both of these aim to reduce flow, improve rhythm, reduce minute volume as a way of turning the volume down on the patient's breathing. And there are other presentations to consider, and I mentioned other things that may be important to consider in our assessment. And again, I'm going to just touch on ILO and EILO now. So these are upper airway components. They stand for inducible laryngeal obstruction and exercise-induced laryngeal obstruction. Essentially, these are the more preferred terms for what used to be called vocal cord dysfunction, where on inspiration, your upper airway closes when it should be staying open. And often these symptoms mimic asthma. So warning signs that it's less likely BPD, and we may need to be considering these in an acute way, is that they're inspiratory in focus. There's a strangled sensation in the patient's throat, often voice changes, smells, odors, and weather change will often act as a trigger, and other also upper airway symptoms as well. But in a key point, they're not responsive to inhalers and nebs. And it's just important that these may interplay with breathing pattern dysfunction, but are also a presentation that is really obvious to see often in acute medicine. And so it's important to recognize. So let's move on now to COVID-19 and our experiences here. That was a whistle-stop tour through dysfunctional breathing. So in terms of breathing acutely, we know that the acute presentation of COVID-19, our ventilation and our perfusion is often impacted, which can cause problems with our breathlessness. We often get a preserved oxygen saturation caused by us hyperventilating to try and account for that low partial pressure of oxygen in our blood. So there's hypoxemia-driven hyperventilation leading to damage. So acutely, we obviously know that there's a significant impact on breathing. And quite often, a small proportion of these patients are ending up obviously with intensive care or high dependency care. But perhaps what we understand less is about the morbidity of COVID-19. And we know that 10% of patients who have mild coronavirus symptoms are reporting symptoms lasting more than 4 weeks. And numbers of hospitalized cases are reporting continuing symptoms of 8 weeks or more following discharge. And there's many studies that are starting to evaluate the long-term health and psychological effects of COVID-19, which are in their very early stages. But it is really important that we start to collect data on the morbidity of this condition. A few webinars that I've attended recently, there were some primary care GPs that have started some focus groups and in-depth interviews, and this phrase long COVID has started to be used. You may or may not be a fan, but the power of social media has started this description. And really what we're describing here are patients who have recovered from the acute effects of COVID. Quite often these are patients that are in the community, and they're starting to report quite common symptoms of fatigue, breathlessness, and functional limitation. This type of presentation is quite a relapsing, remitting nature, and patients are describing feeling really uncertain about their symptoms. And again, clinicians need to make sure that they are empathetic to that, because these are quite often patients that are often fit and well before COVID, and then they're left with this hangover of the problem. And we'll go back to this in a little bit more detail later, but the question for primary care particularly is whether video consultations or face-to-face are important, because obviously it's really important that we ensure that there's no end organ damage with regard to looking at oxygenation and heart rate and cardiac problems. The Royal Free Hospital and UCLH have set up quite a lot of post-COVID follow-up services, which we're also starting to do now for some of our longer-term patients. Quite often these patients had chest x-rays and bloods, and it includes all the patients that came into the hospital, whether or not they were admitted or not. But I think the key point on this slide is that there are persistent symptoms of breathlessness, coughing, fatigue, as well as impact on mental health. And to extend this a little bit more to be physio-specific, my colleague, again at UCLH, Rebecca Livingston, has collected data on her patients, and she's looked at 280 of these and has, through using the BPAT, which is the objective score that I showed you earlier, she's found that 20% of her patients appear to have a breathing pattern disorder. And these are patients where there is an absence of physiology at that point. So other causes of breathlessness have been excluded. And certainly there's a great link with fatigue. So this early data is really starting to describe the morbidity of these patients in more detail. So it's worth us thinking a little bit about where we get support for these patients. We have probably described our post-ICU routes more clearly. They're already involved in healthcare services. It may be that these patients post-ICU have got other end organ syndromes. But I think there's an emerging kind of understanding that long COVID, in inverted commas, may be a sign of post-viral fatigue. Symptoms of that include brain fog, post-exertional malaise and breathlessness. And it may well be that this is where the connection with dysfunctional breathing is clear. Obviously, it's exceptionally important to exclude other reasons for breathlessness. And that's where your decision between face-to-face and virtual assessments is important. And for those of you working in an acute environment, those assessments are really paramount to exclude any other pathology. But I think lots of us have chosen rehabilitation as being an important treatment for these cohorts. But we must remember that exercise is not the catch-all for everyone. Many different societies have set up rehabilitation guidelines, and it may be that different areas of expertise have actually, in some cases, been fairly contradictory. And we know that rehabilitation is available already with pulmonary rehab and cardiac rehab, but it's just important that we recognise that perhaps if patients are struggling with post-viral fatigue and particularly dysfunctional breathing, that usual courses of exercise and rehabilitation may not always be appropriate. So referral to your therapy colleagues is going to be important. And it's important at this point to suggest that if this is a post-viral fatigue, there is already in the literature a quite clear link between dysfunctional breathing, or BPD, and post-viral syndrome. And quite a lot of the symptoms overlap. So I think that's a really important thing for us to explore. Additional places that you can get information from, the BTS is a great resource list for clinicians where they've made some recommendations for follow-up in COVID. And this recognises the importance of assessments of breathlessness as well as rehabilitation needs. But really importantly, also credit the potential impact of dysfunctional breathing. And these recommendations were made quite early on in our COVID story. So the recommendations are up there by our clinicians in these societies. So to summarise a little bit from all of that information, I think there's a high number of patients with continued breathlessness and fatigue post their acute COVID infection. And in follow-up, when BPD is assessed, data from UCLH at least is showing that 20% of these appear to have BPD. We've also had quite a few Twitter chats within our community, and I would say that that is something that is repeated in many places across many different centres, including physiotherapists that work with athletes who have had COVID-19, where dysfunctional breathing and other problems around fatigue are really quite clear. So I think we need to understand more about what long COVID is and its potential connection with post-viral syndromes, which we know is already in the literature. Personally, not only are your webinars really awesome, having looked back at these, looked back at them, but there's also some really good webinars of interest around long COVID, which it may be worth a look. And so these can be accessed here. So the BMJ have done one on long COVID and how we manage it, as well as the Royal Society of Medicine, and both of those have been really interesting for me. So slightly ahead of time, sorry if I'm raced, but I'm happy to go back to anything. Thank you for listening. I must credit a few of my colleagues for some of the data from these slides, as well as some of the pictures themselves. But I'd be really interested to answer any questions or to go over anything if there's anything in the Q&A. Thank you very much.
Oh, thank you. That was really, really interesting, and something I knew very little about before that. We have got some questions. The first one is that presumably in COVID, well, you can't easily diagnose dysfunctional breathing without a some sort of reasonable investigation set to rule out anything else. What is your protocol? Scans, spirometry,
So
etc.
the best way for me to answer that is to think of our unexplained breathlessness clinic, which is quite comprehensive. So I think there's a perfect scenario, and then there's one on the shop floor. So I think your perfect scenario is obviously around your history and firming up a diagnosis, and then ensuring that your symptoms that are presenting are in concordance with your physiology. So the most obvious way of that is obviously getting some data on spirometry, looking at flow volume loops to see the repeatability of those flow volume loops, and looking at oxygenation and ensuring that that's a good trace, a really good starting point. Within our unexplained breathlessness clinic, we do also do cardiopulmonary exercise tests. So obviously that's not possible for an acute scenario. So I think it's really that sense that a patient's symptoms may not be explained by the physiology in front of them, and quite often it's their history as well. The other thing that I would suggest is that signs of air hunger, symptoms of hyperventilation, or other things that might connect you to it. And obviously as well, utilising your therapy colleagues, so your respiratory physios. I mean, I know quite a lot of them have been busy and caught up in COVID and obviously in ITU, but they're a really good resource for you to use as well in an acute environment. But really it's about working out what you do know. So spirometry and oxygenation are a really good starting point.
Okay, and moving on to how things have been managed. Someone's asked, does cognitive behavioral therapy help with this?
Yeah, definitely. So in terms of thinking back over and just going back over the causes of dysfunctional breathing, I think what's important is it's multidimensional. And that's not to say, I think it's important not to think of all of these patients having problems with psychology, because that's not always the case. Quite often their symptoms are quite real and quite distressing. However, obviously, because of the link with anxiety and how that in itself can influence your limbic system and the way that you breathe, then often managing anxiety is really, really important. I would say that we will consider it in all patients, but it's often those that have got treatment resistance where that CBT is much more important. So connecting to your psychology colleagues is important there.
And so I first misread the question as CBD, but we won't go there. So, Miriam's asked, with the move to lots more virtual clinics, how do you see that impacting on this service?
So since all of this, we've continued our dysfunctional breathing assessments virtually, and it is a challenge. Obviously, part of that is ensuring that the camera setup in your environment is as good as possible. It's very difficult to do this over the phone, and particularly if you're not as experienced. We have started to look at self-assessment of breathing, and there's a few websites that take you through that. There's a website called Physio for BPD Group, which have got some really nice test your breathing questionnaires, and we're also looking to adapt the BPAT score that can be filled in by patients. But essentially, looking at patients virtually, what we ensure that we do, and I don't know if you can see me, but we make sure that we have a hand on the top of the chest and a hand on the top of your abdomen, and we basically ask the patients to sit quietly and watch the movement of their hands, because obviously what you're ensuring that you're doing is you're ensuring that their breathing is got a good rhythm, that they're using the bottom of their chest rather than overusing the top of their chest. So there's many things that you can assess virtually, although there are often cases where we might also need to bring that patient in face to face to exclude some other pathologies like oxygenation, for example.
And how easy is it, or otherwise, for you to get psychological therapies for your patients? And has that changed over the last few months?
No, I wouldn't have said it's changed. However, I mean, we're lucky that we have a psychologist as part of our service who is quite busy and is performing a lot of her assessments virtually as well. But there are many other options as well out there. Some of you may have access to IESO, which is an online psychological intervention service for CBT, which is available in some areas around the country. It's certainly available in my area and within London. And so that can be a good option. And that was there before COVID as a sort of online psychological support. And so I suppose it's as well as it's making sure that we all have empathy in how we're assessing the patient, and we think of strategies and refer on patients who are more problematic. The PHQ and the GADS are also quite good questionnaires to help us to screen for depression and anxiety, which can be useful ways of then triggering that referral into the community.
Okay, and just a final question, as we're just about out of time, is with all this treatment, what sort of proportion of your patients with these problems recover or are showing signs of benefit?
Yeah, so nationally there's been some RCTs within asthma where they showed a reduction in hospitalization and improvements in quality of life of patients with asthma, and that was without screening for dysfunctional breathing. So even within the cohort of asthma, it is known that dysfunctional breathing retraining can help patients with symptoms within that condition. In terms of dysfunctional breathing alone as its own kind of entity, we've done some service evaluations in our place of work, and we found that that there's a high proportion of patients that have improvements in their symptoms. There are those that are treatment resistant, and often they're the patients that you remember and take up your time, and quite often the reasons for those patients not to improve is usually psychology.
Okay, well, thank you. That was really, really interesting for us. So
Thank you for inviting me.
thank you. So moving on, we've now got a 4-minute comfort break. So stretch your legs and we'll start again at 8 o'clock. So moving on to our second presentation, we've got Daryl who's actually a course surgical trainee from the Lister Hospital in Watford General. He's going to talk about a specialist medical take, time efficient acute clinical assessment and consultant review.
Okay. All right. Hello, I'm Ari. Actually, I'm co-presenting with Daryl. Daryl is now a core surgical trainee. I'm still a foundation doctor at Watford General. And just a quick shout out to Dr. Dana Lee, who is one of the registrars who did quite a lot of the directing and number crunching in this project, who I think is hopefully listening. So today we're presenting an intervention designed to make our medical take at Watford a bit more efficient. We noticed really the problem. Oh, hang on, the screen's not. Can I have the next slide, if possible? So the problem that we were addressing was that although the national target for all patients arriving at A&E to be seen or treated within 4 hours is 95%. In April 2019, only 81.2% of patients at Watford were meeting that target. So we set out with buy-in from A&E to try to design a way to streamline at least the medical side of those patients. And of course, it should be stressed that while we're looking at targets here, of course, our focus is on improving patient care, which is ultimately the main goal. So what we did was we started off by recording the time taken to key steps during patients' journey through A&E. And we looked at the time they arrived, how long it took for them to be triaged, how long it took for bloods and other diagnostic investigations like imaging to be done, how quickly they were referred on to the relevant specialty, and then how quickly it took for that specialty to assess, and then how quickly it took for them to be seen by a consultant. Based on that data, we our intervention was to subdivide the acute medical take into sort of general acute medical take, and then have a separate cardiology and respiratory specialist medical take, which were staffed by their own registrars, consultants and juniors, so almost run in parallel. And then we repeated our data collection after that to see whether it made any difference. And the results in some ways were quite surprising. There were quite a few cycles of this were done, and we did manage to improve our 4-hour target, though still didn't need the 95% target, but 86% of our patients were treated within 4 hours, compared to 76.4%, which is a different figure to the one before, but was the figure that we got on our first recording loop of where we were at. I think the main takeaway result from this was that only 66.7% of these patients, after this was implemented, required admission to hospital, compared to 100% of the patients who were referred to the medical take prior to this. But that the unfortunately, time taken for individual patients to be seen and for investigations to take place were left mostly unchanged. And here's another slide detailing in a little bit more detail. So people in the grey, we have the control group, which were patients who were seen in the first loop or were not part of this trial. Then we have in blue is the average of all group patients and orange is the intervention group. Blood tests, most of these patients in Watford have their bloods on triage through A&E, so this didn't really touch that. One thing I found quite interesting was that actually in our intervention group, it seemed to take quite a lot longer for imaging to be requested than in the control group. And I conjecture possibly that this is either because maybe having this sub medical take juniors, there were fewer of them available to see each group of patients, so perhaps it took a little longer for them to reach the patients. Or possibly we were requesting fewer investigations, and the investigations that we requested were more appropriate. And then just at the top, the post-take consultant review, I've divided into those who were seen as a direct referral from A&E or those who went via the whole A&E process. So there's a slight difference and they were analysed differently, but what we're still seeing is they're quite long periods of time for consultants to get to see the patient, so in excess of 10 hours really, which is not ideal. What we've shown is that certainly having this specialist medical take with divided cardiology and respiratory dedicated takes does increase the percentage of patients reviewed within the 4-hour target. And the main thing is that it reduces our admission rate for sort of the patients who might be referred to the medical take and kept in overnight to be seen by a specialist in the morning. We get rid of that step, and a lot of those patients can be discharged at the front door. There are a couple of other disadvantages to this, though, which occurred to us once we had put in place this intervention, which was that we were removing some of the specialist registrars and consultants from their dedicated wards, so removing resources from elsewhere, and there was reduced training opportunities for some of the juniors and also some of the more senior doctors in terms of their experience of cardiology and respiratory patients if they were taking part in the general medical take. And with for the acute medical consultants, potential for them to de-skill and perhaps seeing some of the cardiology and respiratory patients. So further work is necessary really to kind of see if we can iron out some of those disadvantages, and I'll address one of the things that we've done in response to COVID in a second, which has improved one thing at least, and see whether we can also improve the journey times of the individual patients going through with similar interventions. We're on the, I think, now 3rd or 4th cycle of trying to improve this, improve our times with this intervention, but we've been COVID got in the way really as emergency rotas were installed. However, based on the experience to this, we have kept a dedicated cardiology consultant post-taking, which has been very useful because it means that a lot of the cardiology patients can be seen and turned around a lot quicker. And this is also got around one of the disadvantages mentioned before, because it meant while we're still retaining a general team of juniors clerking, there's a dedicated consultant who still sees the cardiology patients without reducing the training opportunities for the juniors. So yes, I think it'll be interesting to see what happens after COVID, but certainly these experiences have informed at least the management of the medical take during COVID. And now I'm happy to hand over to Daryl, who will answer any questions.
Yeah, dumping your mate in it for the eye for question. Well, just for one comment from me, that was incredibly brave of you coming here to present something which seems to say acute medicine isn't very good, that your specialist did it better.
Well, I think it's, well, I'm stealing Daryl's point. I think it's more about kind of trying to structure our take so that we're improving the speed at which patients who would be seen initially by the acute physicians, but really needed a specialist review, how we kind of divert them away for the specialist take and get them seen quicker.
Yeah. Just one question from me is, and I might have missed it, but pre-intervention, every single one of your patients got admitted. Do you have a ambulatory care or estate unit there where patients could have gone to? I'm just thinking it's highly unusual for 100% of patients to get admitted into any acute medical unit.
That is definitely very true, and I think on an ordinary circumstance, of course, we do have an ambulatory care unit, which we would obviously circumvent our patients to. It just so happens that the 20 patients we were randomly allocated for using the same procedure on both the pre-intervention and post-intervention group all happened to be admitted. It was sort of just luck of the draw, using the same method of selection between both of those groups.
Do you think that, given that what you've just said, that you do actually use ambulatory, do you think that throws a bit of a light on the results of all the results if that group weren't entirely typical of what comes through your doors?
That is definitely true, and I think it's something, seeing as we are intending to do many further iterations of this to try and improve our timing, it's definitely a completely helpful thing that we'll take forward onto the next stage.
And how did you achieve the miracle of getting a cardiologist to the front door? And how many patients did they actually have to see?
So thankfully, I mean, most of the time it was the benefit of actually having the cardiology consultant or the respiratory consultant who was in for the day anyway, and it was just adding on to their responsibilities, asking them if they would mind coming down to the department in order to help us to further sort of reduce what was going to come through their door essentially the next morning. So they were more than happy to come down and assist. And I think from the side of the acute medical consultants, they were more than happy to allow for this in an attempt to sort of speed up the process and reduce the workload on their side as well, so that things were just all happening overall much more efficiently.
It'd be interesting to find out how your acute physicians actually feel about this moving on, because I don't know how many acute physicians would actually love to divvy out their work and give all the bits to other people and leave them with the undifferentiated, but we'll leave that now.
Yes, I think overall, surprisingly, they were actually quite happy with it and happy with the procedure, because it did. The procedure worked very well to get rid of the short-term patients who could be discharged very quickly. If a patient was going to be admitted, they would still be admitted to the acute medical unit in the interim anyway, so they'd still be seen by an acute medical consultant the next morning. But it just helped to sort of relay things appropriately so that people could be discharged relatively quickly where possible.
Okay, well, I think we've just about run out of time for that. So if you manage to look in the question and answer bit and type in any answers to any questions that we haven't got through, we'll be very grateful.
Of course.
And now we've got our last quick abstract presentation, a quite change of subject. We've got Laura Harrington from University College London, who's an acute medicine registrar, who's going to talk about internal medicine training in clinical practice and human factors. Thank you, Laura.
Hello, everybody. I hope you can all hear me. My name's Dr. Laura Harrington. I'm an acute medicine registrar and a medical education fellow at University College Hospital. This evening, I'm going to talk about the abstract I submitted entitled Internal Medicine Training in Clinical Practice and Human Factors, an Interprofessional Simulation Approach. I'd also like to thank my consultant supervisor for this project, who is Dr. Ben Lovell. So to start with, I'm going to talk a little bit about the background to our project, what our aim was at UCLH, how we did what we did, and some outcomes and how we can apply this to our clinical practice. So firstly, what is interprofessional education? So interprofessional education, I'm sure you've all heard the term before. It's when two or more healthcare professionals from different backgrounds come together and act authentically and constructively to try and improve patient care through education and training. We have all found ourselves, no matter what our background or our job role on the AMU, suddenly in a very acute and complex situation. And in order to manage this effectively, we need good teamwork, we need good leadership, and we need good communication. And we rely on these in order to get it right. And when we do get it right, this improves patient care, which is why we do what we do. So an overview to what we did. Oh, I'll just go back. So while we appreciate an interprofessional approach is not necessarily novel, and many other centres are doing it, especially now simulation is mandated as part of the IMT curriculum. What is new about what I'd like to talk about this evening is the analysis of what the interprofessional approach means and what our learners feel as a result of it. So we aim to evaluate our course. We evaluated 7 courses over 2019 to 2020, and it was a one-day simulation course made up of IMTs and our nurses from the AMU of varying different grades and backgrounds. We worked our way through 5 acute medicine scenarios throughout the day, trying to explore the different behaviours and human factors and non-technical skills that can influence the way that we behave and act at work and subsequently affect our patient care. So to give an example of one of our scenarios, the anaphylaxis scenario was a 51-year-old lady who had a background of breast cancer, was going through chemotherapy in the community and is admitted with a fever and breathlessness. The 2 candidates that start in the room at the start of the scenario is the IMT doctor and the nurse. So whatever medication they administer, the patient then develops circulatory shock, develops anaphylaxis, and then anaphylaxis management is commenced. So rather than drilling the candidates about the knowledge of the sort of protocol on how you manage anaphylaxis, the learning outcomes that we intended to achieve were more focused around the non-technical skills. So recognising a deteriorating patient. It was very interesting to see, so does the nurse recognise it first or does the doctor? And quite often it was the nurse, as is what happens in real life. And it's interesting to see how they communicate this deterioration, and do they communicate it early? Assigning leadership, so in a suddenly very complex scenario, how do they assign leadership and who should take the role of leadership, and how is that delegated within the scenario? And then finally, knowing how to call for help and knowing who to escalate to. So whose idea is it to escalate, or do they both try and manage it alone? And how do they communicate that they want to escalate it, and who to? So like I say, our focus is much more on these non-technical factors, both within the scenario itself and then much more in the discussion in the debrief afterwards. So our method was a mixed method approach. We analysed feedback from the learner questionnaires over a 1-year period. We had 62 participants over 7 courses. 58% were nurses and 42% were doctors. We used both qualitative and quantitative data. So our quantitative data was the Likert scale completed by the learners both before and after the course. And then our qualitative data, which we believe gives us a much richer level of detail, was a thematic analysis approach. So by 2 different independent analysers, looking at the free text comments on how the learners felt and how they would apply this back to their clinical practice. So our outcomes. These statistics confirm that our learners were satisfied with the education that they received. So 95% felt that the course matched their needs, that it was relevant to their practice, and that the course itself increased their knowledge and understanding of what the term human factors and non-technical skills meant. 98% of learners felt that the interprofessional approach made the delivery of their care more effective when translated back into their clinical practice. And 92% of learners stated they had identified specific things that they hoped to change. So whilst this does tell us that they were satisfied, it does of course not tell us how this impacted their practice and subsequently their patient care over time. And what I really wanted to talk to you about this evening, and what we're quite proud of, is the thematic analysis, which, like I've said, gives us a much more richer level of detail on how our learners feel. And this can reveal to us what our hidden curriculum is. So despite what our intended learning outcomes set out for the day were, these were our actual learning outcomes and what our learners took away from the course and what they're saying about this interprofessional approach. So team communication. So often we do things subconsciously, especially in acute scenarios, and there are subconscious behaviours that we can bring to the forefront of the discussion, both within the scenario and then in the debrief after. Clear delegation of cross-professional tasks. So particularly with the perceived hierarchy amongst professionals that can still exist, and how somebody can feel when they've been delegated a task and how this task is delegated to them in an acute environment. Collaborative de-escalation techniques. So doctors and nurses, particularly when dealing with upset or angry relatives, knowing who they can rely on in such a scenario and feeling able to speak up and drawing this into the discussion after in the debrief. And finally, recognizing and escalating unwell patients. So again, being able to feel like if they've maybe recognized a deterioration earlier, they felt able to escalate this fashion. And to say, drawing out these reoccurring themes that were continuously mentioned when looking at the learners' feedback over the year. These were the 4 reoccurring themes. So this was what we actually felt the learners were receiving as they defined themselves in their feedback. And then finally, in particular, the nurses, it was interesting, they commented on how useful it was to work with doctors in a training environment. And this alone would help them, and they would take this back over to the AMU in their everyday work. As we don't work in isolation on the AMU, we're all a team. And so training in a team environment and mixing together can improve your teamwork and your bonding, because then you may meet across a real life acute scenario back on the ward. So in conclusion, interprofessional simulation open door to collaborative learning in acute internal medicine. It matches the learner's needs and it's much more applicable to clinical practice. We hope that other simulation-based education programs are adopting this approach. And finally, it's fun. And that was a very common theme highlighted across all of the learners, that they enjoyed it, which I think is really important in any education program.
Thank you.
Happy to take some questions.
Thank you. That was really good and really interesting and totally relevant to what we do and how we do this. Did you pick anaphylaxis as it's something that's done by a lot of people in ALS, or did you pick it for any other reason?
I think the 5 acute scenarios that we picked were more because it wasn't really about the clinical medicine itself. It was much more about the acute setting and how people behave. Anaphylaxis is something that often triggers a lot of panic, and it's a very stressful environment, and this brings out those sorts of behaviors. So it was more just the focus, rather than on anaphylaxis itself, was more on the human behaviors that sort of happen as a result of an acute event.
And just one last quick question as we're running out of town. How did you manage to get all the nurses released? Because that's something we really struggle with, getting nurses released from either shop floor or coming in on their days off to do this sort of thing.
Yeah, absolutely right. It's really difficult. And we work with a clinical practice facilitator. So as part of the education and simulation team, we've got a CPF that works, a nurse that works as part of our team. And she works with the CPFs back in-house on the wards, and she works with them to create a timetable. So it's set out in advance, it's structured. But like you say, there's always more doctors available for these courses than the nurses, which is why I think we continue to do them and continue to do them frequently. So try and give nurses the opportunity, because it really is invaluable.
Thank you very much. I think there's one further question in the Q&A about in situ training that you might want to have a quick look at if you get a chance. But moving on now to our last plenary session of this day is Dr. Paul Sullivan from Imperial College London, who is our QI guru recently for SAM, and he's talking about the quality improvement in acute medicine. Over to Paul.
Hello, hi. So I'm Paul Sullivan, acute physician. I've been having quite a substantial part of my role for the last 10 years in quality improvement in various formats. So I've tried to boil down some of the experience into some sort of key points. And I have to say that I'd anticipated that there'd be a lot more juniors on the audience today. But it looks as though there's a lot of consultants and everybody's got quite a high level of improvement knowledge. So I'll need to adapt as I go along. So the first thing to say is that QIPs are now part and parcel of the development program for trainees. And so consultants will have a role in supporting their trainees, but consultants will also be feeling the need to be involved maybe in quality improvement projects at trust level. There are national level programs, for instance, those based on the RCP audits. And so there are many ways in which you might be asked to be involved in a quality improvement project. And we might not in the first instance really know what to do. The first thing to say is you can't do these things on your own. It's very important to have relationships, and those relationships for somebody who's a trainee might be with a mentor, or with the Trust Quality Improvement Department, or with external bodies, NHS Improvement, Institute for Healthcare Improvement, the Royal College of Physicians, and with SAM actually have resources for quality improvement that may be able to help you. The first question that needs to be addressed when we're starting to think about a quality improvement project is, what exactly is it that you're going to improve? And it's a lot more challenging than it might at first seem, because in order to answer that question, you're going to have to think about what exactly is it that is quality in practice. And very often we think of things that are internal to our working practices and things that affect the staff more than the patients, and things that affect some of the metrics and some of the targets that we have that might be important for trust kudos or income or whatever, but might not be directly important to patients. And so the question that's fundamental to quality improvement, and which probably, if you had to just pick one bit of the whole gamut of quality improvement techniques and methods and tools, and just pick one of them to underpin a project, is just to choose what it is that you're going to improve. And so many things that we do, so many things that we're asked to do, maybe by management, aren't really based upon an overarching patient-centric quality. So who can tell you what quality is? I mean, at one level, it's easy to talk about what quality is when you're buying an iPhone. Let's say, you know, battery life, screen quality, whatever. Or you're buying a car. If you're buying a car, there are lots of things that, if you're that sort of person, you might research. Safety, petrol consumption, whatever. But when we think about quality in healthcare, it's much, much more difficult to pin down exactly what is quality, and particularly to pin down exactly what is quality from the point of view of the patient, because they're the customer. So how can we think about the quality of what we do in acute medicine in terms of patient needs, patient wants, patient's desires? I'm sorry, I'm having a small technical hitch. And, you know, if you ask patients what they want, if you think about what you want or your family would want going through a healthcare experience, remember, for many of the patients that we see in acute medicine, they're going through a terrible healthcare experience. You know, they're going through something that may be life-threatening, or even if it's not, it feels as though it might be life-threatening. And what do patients want? They want to be free of pain. They want to survive the episode. They want as short a hospital stay as possible. They want to have information on what's happening. They want to feel confident in the staff. These are the things that I put on here, are things that come out of patient surveys and patient interviews. But there are many, many things that we maybe don't focus on enough. And one of the ways of looking at quality that's quite useful is to boil it down into elements. And the Institute for Healthcare Improvement, many people will be aware of that, talk about the triple aim, which could be translated into safety, effectiveness, and experience for patients. So the effectiveness, how well do we treat the patients to get the best possible clinical outcome? Safety, that we don't harm patients. Experience, that the patients get the best possible or least bad possible experience. And the other part of the triple aim that I haven't put on here is cost and value, because that's much more difficult for us to control at unit level. A fourth element that might go onto here is staff experience. And many lists of metrics for quality improvement include staff experience. I've found that if you include staff experience when you're dealing with a group of people who you're trying to teach quality improvement, they gravitate towards staff experience and start to ignore the other ones. So I prefer to leave it out of the little Mercedes-Benz sign that we have here. And so many people will be aware of the model for improvement, and the model for improvement is something that's really looks very simple, but actually is tremendously effective, and is something that we don't practice enough in the NHS. And that is that we start by thinking about what are we trying to accomplish and being very clear about what we're trying to accomplish. And I don't know about everybody else here, but I know that I've been to very many meetings at various levels within trusts where people have ideas for changes that they want to make, but they are absolutely blank as to what they're trying to accomplish. And in many instances, what they're trying to accomplish is to get their idea over and to achieve implementation of their idea without actually knowing what it's going to do for patients. So the first thing that the model for improvement talks about is what are we trying to accomplish? And only when we're very certain about that do we move on to the second part of the model for improvement, which is how do we know that a change is an improvement? And this is the second key foundation of quality improvement, which is what are you going to measure, essentially, to tell you if what you're changing is an improvement. And again, this is much more challenging than you would imagine. It can be very difficult to work out what you should measure. We'll talk a little bit about this later on, to mirror the improvement that you're trying to achieve. And only when you've got these two things worked out, and if you're doing a project that lasts a year, it wouldn't be unreasonable to take 6 months trying to work those first two things out. Can you move on to the fun bit, which is what changes can we make that will result in an improvement, and start to actually try and test them out. And the fun bit, everybody likes trying to come up with ideas and fix things and solve puzzles. So people are attracted to move on to that last bit, maybe more quickly than they should, but it is absolutely critical that people move through the first two stages of this model for improvement before starting to actually try to make changes. The other key thing about quality improvement, and something again that is challenging, is that you really need to be looking at time ordered data. So many times we look at before and after data. So we have a bar chart before an intervention and a bar chart after an intervention, and we try to show the difference between the two. But there are lots of statistical reasons why that really isn't a very good approach. And also it doesn't take into account the way that things change over time, so that you don't know whether your before period was just a downward blip that you've come back from, and you don't know whether the change that you've seen is just a trend that was happening anyway, and you can't really see exactly when things changed, because by and large, when you do a quality improvement project that works, you don't just do one intervention, you actually do many interventions in a row, adapting them and tweaking them and maybe abandoning them and starting from scratch. So that you do over, say, a 1 year project, you might do 10, 15, 20. I've worked on projects that have got 180 interventions, and without the time ordered data, where, as in the chart that you can see here, if right in the middle here, you're on your 15th test of change and suddenly that happens, you know which one worked. The time ordered data also tells you whether the improvement that you've made has sustained, because many things that we improve have a short-term effect, if they have an effect, which dies off. And so getting time ordered data is critical, and it's really difficult. First of all, working out what data to get, the data that will reflect the change that you're trying to make, is difficult. Secondly, and very importantly, trying to work out which patients you're trying to sample, and then actually getting data on those patients is also difficult. You might find that you want to do it by just getting data on coded patients, but then coded patients come many weeks after the coding comes many weeks after the discharge, so it's not real-time data. Coding is often up to 50% or more inaccurate in terms of accurate diagnosis. And then if you find that that doesn't work, you may find that you want to go and actually gather real-time data on patients on the ward by searching notes, searching records. That's tremendously time consuming. And not only that, if you want continuous data, unless you're very careful and you put in stop gaps and safety nets, you find that somebody goes on leave, somebody goes off sick, and your continuous data collection is interrupted. And one of the reasons that I said a little bit earlier on that, you know, if you're doing a one-year project, you might think about doing 6 months and getting the data collection and the definitions and so on sorted out. Is it really does take that long to get a data collection program that works. And many projects, if not most, at the end of the project fall down, not because they haven't necessarily achieved, but they haven't managed to get the data to show the achievement that they've made. Second, another key point about doing quality improvement, sorry about this jumping, another key point about doing quality improvement, and one that it takes a little bit of getting used to, is doing quality improvement or leading quality improvement is not about having ideas, and lots of, you know, it's great fun having ideas, but doing quality improvement is about enabling and facilitating other people around you, people who are frontline workers, people who are working within the patient pathway, to have ideas, express ideas, and to implement their ideas. And so quality improvement is not about telling people what to do, but quality improvement is about getting people into a room. And many of the tools and techniques that we use in quality improvement are about standing at the front of a room with a lot of people in the room, hopefully people from multidisciplines who work around the problem that you're trying to solve, and not dictating to them, but actually getting them to brainstorm their ideas, think about what the processes are, standing with a whiteboard, marking all that down on a whiteboard, but not because the thing you take away at the end as a map will necessarily be the be all and end all, but because you've got people talking to each other and networking their ideas and actually being creative. So we use tools like this, which is like a drive diagram, where we get, again, with a room of people trying to get their ideas and their knowledge from different perspectives about, in this example, how do we improve post-op analgesia? And makes me think of one of the presentations that we had earlier. And in fact, many of the things that we heard about so far today are, you know, really good quality improvement topics and quality improvement projects. So, you know, you might find that you might think in your head it's relatively easy to get patients analgesia, but when you get the reflections from healthcare assistants and nurses and maybe patients, if you can, you might find that there are many things that you need to do. And being able to get people's ideas onto a board and break down their ideas into a list of doable actions can be a tremendously powerful technique. And you'll know, many of you will know, that there are process maps and stakeholder maps and swim lane maps, all sorts of techniques that people use to put things onto a whiteboard. But the reality is all of them are actually just to get, above all, to get people talking to each other about the problems that they're working on. So how does a patient get a PRN analgesic? And in a session that was a lot more interactive, we might sort of talk about that a lot more, but, you know, I reflect on a project I have been involved with, and the outcome of all of those processes of doing process maps and getting people into the room was a surprise to everybody. And the outcome was, after a lot of multidisciplinary work, we realized that patients don't get PRN analgesics because they don't ask for them. And they don't ask for them because nobody told them that they could ask for them. And completely changed the approach that we were taking around projects around PR and analgesia. And yet it wouldn't have happened if we hadn't had these group sessions. Another thing said about quality improvement is that actually really what you're trying to do is to get somebody somewhere in the shop floor to, in a certain circumstance, to do something differently. And that is tremendously challenging and difficult and cannot be done easily. And that's one of the reasons that we talk about doing 180 PDSAs, you know, lots and lots of ways of trying to get something done. It's incredibly challenging. We can't get other people to do what we want them to do easily. And if we could, we probably wouldn't be in this job. So this is why we have the project, the idea of the PDSA, Plan, Do, Study, Act cycle, that I'm sure most all of you will have heard of. And the idea that we actually have to try things out because we are actually trying to work on making other people behave differently, which is not easy, and it never works the first time, and you need to try and try and try and try it again. And the only way to try these things, and the only way to find out if your ideas work, is to try them in the real world, because the real world is so complicated that however much you think that you understand how your unit works and how people will react and respond when a change is made, or a new protocol is put in place, or a new education session is put in place, or new posters are put up, which is often the first step in a quality improvement project, they won't respond in the way that you think they will. And the only way to find out is by trial and error. So important things to consider in a quality improvement project, to recap, are you really have to be clear on what you're trying to improve. Is it analgesia? If it's analgesia, it's not getting the tablets to the patient in a set time, it's their pain score, average pain score at a set time. Is it patient experience? If it's patient experience, it really isn't whether they would recommend your unit to their friend and family, which is not a tremendously good test. But were they in pain? Were they scared? Could they get somebody to talk to? Concrete things. If it's about outcome, often we can't measure outcomes, but it could be, is it that you got the patient to the cath lab within 90 minutes, what we call process measures. And finally, something to really think about when you're doing a quality improvement project is that very often you think that your project is to reduce X by Y% by Christmas. We're going to reduce length of stay for COPD patients to an average of 4.5 by Christmas. And sometimes that works, sometimes it doesn't. But the thing that comes out of quality improvement projects, much, much more than that, is the way that it changes the people who are doing the project, who are involved in the project. And it's very transformative. And my experience has been that the biggest changes that come out of quality improvement projects have been not during the index project, but have come afterwards, where people have done a project, got interested in quality improvement, gone on maybe into leadership roles, maybe not, but have championed improvement and thinking about it in a patient-centered way, thinking about measurement, thinking about tests of change in their future career. And people get very specific things, because you might find that you end up talking to tiers of the organization, you know, senior people that you wouldn't have otherwise talked to, or you would have been anxious to talk to. Or you come out of the project and you've got now a new network of people who you wouldn't have been talking to before, across other disciplines, in other departments. Or come out with a changed attitude, come out thinking not, oh, this is just the way it is, but actually we can change things. And we can aim to change patient experience, patient outcome. We don't have to put up with the fact that this is the way it is. So very often, the improvement in quality improvement is actually in the person doing the improvement. And that's something to remember and to try and build in and be conscious of while you're doing projects.
Good line to finish on, Paul. So I know we're a bit tight for time now.
That's it. That is my very last word.
Oh, it's a brilliant ending then.
And 19 minutes and 59 seconds.
Okay, well, we've had a couple of questions if you've got a couple of seconds. The first one is someone who says there's no sort of uniformity about QIP between hospitals, between teams at a national level. It's difficult to know who's doing what, and it's hard to get support from a trust. The other question we've got, which you might have to think about, is how do we make certain that QI is actually done properly? And I can relate to that, having just read through hundreds of applications to ST3 in acute medicine. But how do we make certain it doesn't go the way of clinical audit when it's seen as a tick box exercise on the ladder to the next stage?
So first question, uniformity. Actually, I think there should be uniformity insofar as the NHS has taken up very much the model of approach which has been promoted by the IHI in the States, and NHS improvement very, very much. Royal College of Physicians as well, SAM as well, and many, many bodies are using a very uniform approach to quality improvement. And I mean, there are lots of ways of doing things, lots of ways of doing improvement. And it is important that we all try and do the same thing. And we are therefore trying to strive towards uniformity. How can we, what was the second part of that question?
How do we stop QIP becoming a tick box exercise rather like some forms of clinical audit have?
Yeah, well, that's really difficult. And for people who are trainees doing a QIP, in many ways, you know, quality improvement is really, really hard. Quality improvement is often quality improvement projects. The quality improvement projects that I worked on when I was working in Clark, Northwest London, we gave them £100,000 to support their project. And you know, so that employs project managers, support staff, IT staff. It's huge. So as a trainee doing a quality improvement project, it's really, really challenging and difficult. And in order to make a change, you might not have enough resource. But coming through a quality improvement project, I'd come back to that last slide. It can be incredibly transformative. So you can learn about barriers, you can learn about networks, you can learn lots of things about change. So I don't think, even if you do a project that doesn't necessarily result in a massive change, it's just a tick box exercise, because in the way that audit doesn't, it exposes you to lots of aspects of the NHS that maybe you wouldn't otherwise be exposed to.
Great. Thank you very much, Paul.
Thank you.
Thank you for bearing with us to the very end. For those of you who are interested, Chelsea are currently beating Tottenham 1-0 in the cup. But moving on to our last few questions we've got for you. A poll to see how you've learnt from today's webinar. You have those up, please, Tim. So, closing poll. Compared to the beginning, what's your understanding now of the off-site consultant working in ambulatory care? A lot higher, and I suspect a lot of people are very interested in it. Second question regarding disordered breathing, dysfunctional breathing. What is your understanding now of this subject? Much higher. And the third question on the last talk, remember we start off at a slightly higher baseline. What's your understanding now of QI in acute medicine? There's been some improvement there as well. So once again, thank you to all our speakers. Thank you to all our participants. Thank you to Aventage and their team who have asked us to register all for SAM Glasgow. So how many of you have actually been onto the website and registered to date? bit of work there. 84% of you still need to go onto the website. We will be running something in November. You can register as an online delegate. You can register to try and go there in person if we still manage to get that, but we will at the very least deliver something online for you on the 12th and 13th of November. Thank you all for joining us. Hope you have a good evening, and it's now goodbye.